Right, so we left off at VTE. We did fat embolus, right? Yes. What are those 5 P's that you're looking for?
Paresthesia, paralysis.
Pain, pulse, pallor, paresthesia, paralysis. Is that all 5 of them? Yes. All right. And what are you looking at it for? Neurovascular checks, because
you want to make sure there's circulation.
Yep, you want to make sure there's circulation. Bottom line, that's simple. Where's Mindy?
She's sick, I guess.
Sick of what? Me? Okay, better check my email, right? I don't know about you, but I've had some issues with grading, the grade center, trying to see your grades. And has everybody able to see their grades and view? Okay, maybe it was just my computer. Something about cache or catches, or I have no idea what that is. Catch. All right. I couldn't catch my grades.
You probably just have to delete your catch out of your internet.
Yes.
And then you can view it.
Something like that. Did I know how to do it? No. So yeah, if you have issues, make sure I get an email. I put up there about the brain dead. Your last Camtasia, the accessible one. What do you call it? It's got printed closed caption. Does anybody use closed caption here? Mm-hmm. All right. Did you check it yet?
No.
All right. I need an email sooner than later if you want it in optimum form, because I need to submit it, have it redone, and there might be issues with static in there.
Don't worry about it.
There is.
Yeah, there is static. Well, there's static on the original, on 3 and 4. MP3 and MP4. MP3 and MP4.
For Tuesday's class,
yeah, a little
is
bit.
it audible?
Yeah.
Then that's not an issue. I'm talking about, can you not, so nobody's really done the closed caption one yet?
I did, and there are parts where you cannot hear it.
You can't hear it? Is there wording, or they can't?
You can't hear you for quite a period of time.
Quite a period of time.
The static.
Okay, all right. I'll resubmit it and have it done, but it's going to take probably at least a week. So that's why I need to know, like, right away if there's an issue with any of the setups. So I can find either an older version or some other way around it to fix it so that you guys can get the format that you like. Okay? All right. Is everybody nice, warm, and cozy? Because I'm sweating my butt off. Got a coat? I'll stand by the window. I won't give you too much light. Hang on a minute. Let me do this real quick, and I'll put this back down. Oh, man. I need some upper body strength. The sun is nice? Okay. Well, all right. Somebody with some upper body strength, please.
It's not so nice when the cold air
Shoot, give me one. Okay, I'll stand right here.
You want it closed more?
Yeah, close it a little bit. Thanks. Thank you for that upper body strength. Okay. I'll sit right here as I drench. Man. What do you do if I fall and I don't get up? Where is it? Where is that AED? Anybody ever look for it? Health lab?
It's down there, I guess.
Jim's a little far away. If you really want me dead, that works. Okay, so we talked about fat embolism. We're going to look at the difference between fat embolism and VTE. If you know if somebody's got one or the other, you're not really going to know diagnostically unless they're on the morgue table. But you do need to know what things to look for, right? So I'm holding your hand here. You've got that nice page 1314 up there for venous thrombus event, or venous thrombus embolus, however you see it designated. So that is the new term for the DVT. You're going to still see DVT used a lot by old farts in the medical setting. Docs that don't want to learn. But that is, and you'll see some new residents that have not learned the new terminology. So you can go in there and teach them something. How about that? Dr. So-and-so, do you mean venous thrombus event or venous thrombus embolus? Do you realize that all deep veins are not the only places where you can get a thrombus? Blood clots form in the intimal lining of a large vein. And they came up with DVT or deep vein because it quite often is in an iliac vein in the leg or the pelvis. But it can be anywhere in there. Can be a deep vein, can be superficial, and be in a lot of different areas. So it can lead to a pulmonary embolus. So your risk factors are more commonly, very commonly, post-trauma patients. What other type of patients would you see? Anybody? Who? Strokes. Okay. What else? Basically anybody that's not moving, right? Like they are at home, up walking around. What type of patients would they be? Elderly. Especially those elderlies taking those drives down to Florida and don't want to take that stop because that male in the car driving just doesn't want to stop. And the wife's saying, I gotta pee. You know? And then he'll stop if he's got to pee because he's got to stand up to pee because of his BPH, right? But that's the issue. People that just want to get somewhere and they don't want to take the time to get up and walk around. So that's some education you can do in the elderly population, right? For all your snow, what do they call them? Snowbirds? Okay. Snow bunnies? Okay, snow bunnies, snowbirds. Think about your church.
Snow bunnies are scared.
So think about your churches, okay? The people that are in your churches or your community settings that are leaving for the winter. That's a little extra something when you're checking their blood pressure before they go. Is to say, you know, don't forget, make frequent stops, get up, walk around, stop for coffee, and then 2 hours later that coffee filters through your body and you can stop and make another stop. So it's important. And that's another thing why you, in the hospital setting, who was our very uncooperative, what's another thing to call her? I don't know what else to, what was her name? Mrs. CC? Yeah. Mrs. CC, who was just didn't feel like doing much of anything, right? And what did she run into? She ran into big issues there, right? Okay? So not only did she get the proper education, maybe she just didn't understand what risk she was at, or maybe she just didn't care. Maybe she had a death wish.
Sarah said she was fat and lazy.
Okay, that's a little subjective, Sarah. But anyways, you know, maybe they just don't have enough education, okay? Try to give them the benefit of the doubt. Anyways, so you're responsible for giving them that education, right? You can only lead a horse to water is another way of looking at it. So it's very important that you are able to identify this population that are at risk and what can you do to prevent it. We are even currently in the hospital, nursing staff have to give our doctors a little reminder via the computer to make sure that they order some sort of DVT, VTE prophylaxis. OMG. Who's making the big bucks here? And why do I have to remind them when I'm having a hard time remembering myself? But anyways, it's actually built into our system right now. We actually had to go through some mandatory training because this is so important and it's basic. It's like knowing what is a normal blood pressure range. This is something that has to be taught to everybody coming into the hospital. It has to be followed up. There has to be some sort of prophylaxis on board. Anybody know what type of prophylaxis I'm talking about? Compression stockings, TED hose or SCDs. What else?
Ankle pump?
Doing an ankle pump, yep, you can do that by dorsiplantar flexion. You would have to do that for a couple minutes every hour while awake. What else? Pharmacologic, like heparin, sub-Q heparin. What kind of dosing would you see for sub-Q heparin? How much? 5,000 units. How often? Every 8 hours could be. Yep, yep. It could be if it's 5,000 units. If you have for somebody that's 70 kilos or approximately 150 pounds versus a 300 pounder, might you see higher dosing for heparin sub-Q? Absolutely. It might be 7,500. Or whereas one person might have 5,000 units sub-Q BID, another one might have it 5,000 Q8. Depends what are the risk factors for developing this, right? And somebody mentioned Lovenox. So definitely Lovenox. What kind of dosing do you see for Lovenox?
30 milligrams a day for over 200 pounds, lady.
So 30 milligrams sub-Q daily?
Yes, it was.
Okay, for about approximately 200-pound lady. Okay, you might also see 40 milligrams. So that's kind of your range for Lovenox, and that's usually daily dose, and that's sub-Q. All right. So the types of things that you look at. What else do we want to look at for there? So your precursors, venous stases there. What type of people might have venous stases? Or sluggish blood return to the heart. People on bed rest, okay? CHFers, yep, their pump's not working very good, so that blood's not circulating real well or consistent. Who else? Thinking over time. CHFers or anybody in heart failure, right? So circulation. Who else has circulation? What kind? Elderly. Yeah.
Severe varicose veins.
Varicosities, right? Varicose veins. Paraplegics, sure, because they're not moving, right? You get contractures and that muscle wasting. Absolutely, absolutely. Ding, 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 ding. Diabetes, and how common is that becoming in our obese population? More common, right? Because we're all eating, at least I am, eating way too much and not paying attention and not doing enough exercise. Yeah, 2 miles a day is not enough. So you have some sort of problem with decreased blood flow, right? You can also have up there that is blood vessel injury. So I apologize if I am abbreviating too much, but that's a blood vessel injury for one reason or another. You know, you got injury, bruising. I remember another story from where is it that I live near? Morley, Michigan. A guy whacked his leg. I can't remember why or how. I think he was cutting down a tree or something. Hit his leg, calf. Went to bed that night. Never woke up. He was in his 40s. He had, yep, blood clot. Killed him in his sleep. Nice big old hematoma in that calf. So he had definitely had some sort of injury to that blood vessel, right? Massive hematoma. And it was probably the size of maybe my fist. You know, it's just swollen and hard in his leg because he hit and injured it. You know, for whatever reason that you have blood vessel injury. Could be chemically induced, could be, you know, pathophysiologically induced. But altered coagulation. for one reason or another. People that have genetic issues, right? That they can have problems with that. Increasing production of platelets and clotting in an attempt to maintain homeostasis. If you could have some reason that's causing your blood to clot in order to stop bleeding, like your body picks up that I'm losing hemoglobin for one reason or another. Could be a genetic reason. Think about factor VIII deficiency, a kid that was fell and bruised a joint or something, and his blood's starting to clot or trying to heal because they're starting to bleed quick, so the body's trying to react and maintain homeostasis. So then they're going to use up the platelets, so they could be going to the wrong place and clotting in the wrong area. It could be altered coagulation from somebody that's sick and their immune system's starting to break in and have issues with that. You know, anything that's heading you down that path of DIC. So it could be strep, pneumonia, going into a bacteremia where the infection is going into your blood. Yes, Sarah, what you got?
What's DIC?
Disseminated intravascular coagulation, where your blood, you've just used up all your clotting factors and now you're hemorrhaging. That could be, sepsis can happen. It can happen in a hemorrhaging situation, motor vehicle accident, traumas.
Can you say it one more time?
Yeah.
Is it what?
Can you say it one more time?
Disseminated intravascular coagulation. Okay? So this altered coagulation could be for a variety of different reasons. Okay? So when you got somebody that's having some issues, then you got to start thinking about this. What's working in the body? What can be affected? And what do I have to do about it? What do I have to be thinking ahead and anticipating? All right? So your signs and symptoms. Do I have diagnosis up there? Okay, yep, okay. Signs and symptoms. Remember Mrs. CC? She may have, the person may have those, or they may not, may only have a part of it. So they may have some swelling. What if they weigh 300 pounds or 500 pounds? Are you necessarily going to see it? Maybe not. Okay, so they may have all those symptoms or maybe just part. But think about, if they're complaining of pain in that area, in their calf or something, then what do I have to be thinking of? What might cause them? Well, Mrs. CC, you haven't been getting out of bed. That's an issue. We're going to do something about that. We're going to order a Doppler ultrasound. They may want to take a peek with a little tiny ultrasound like you do with your pulse oximeter or your Doppler. You know, the little Doppler that you check pulses with? Well, this is just a bigger one. Same thing, does the same thing. And you'll see on these Doppler ultrasounds that they can do at the bedside, they'll just run it right up and down the leg, and the tech can see right on there where there's an issue with circulation. So that can be done right at the bedside. They may have to do something more invasive like a venogram or an MRI if they're looking, especially if you're looking at a showering of blood clots, where one clot, you know, where it might have broke free and it's just showering going everywhere. And they're starting to have mild symptoms, but you're having symptoms in different areas, like a TIA, and I'm getting short of breath, and what the heck's going on with this person? Are they trying to have a stroke and a PE at the same time? It happens. And it happens, I see it with traumas. So your prevention you want to do is anticoagulants, right? We want to prevent anybody that comes in the hospital, it's not going to be moving around unless it is for some reason they can't have heparin or Lovenox. They got to have something. Throw SCDs on them. If they're trauma and they can't have it on one leg because they just had a ORIF of their tibia on their left leg, well then, doggone it, we got to find something else. And maybe we can do sub-Q heparin if they don't want Lovenox, or what, Maybe we're going to do those goofy little, they call them DPFs. They tap the bottom of your foot. And then I think it's shown, I've seen Spectrum Health use that. It's more like a last ditch, and I'm trying to think. Plexipulses, anybody know what those are? Yeah, they're pretty much useless as far as evidence-based practice. But they still use them, and you'll see them used more often if there's a really high risk of that person getting a thrombus. Think about somebody that's pregnant. What if maybe they can't have a pregnant person that was in a trauma, you know, and she's got broken legs or something, and they're worried. You know, they're going to try whatever they can because something's better than nothing. And you got to have at least one of the three, something going on. Because if you don't have somebody with TED hose on, or SCDs, or heparin, or Lovenox, if you don't have something on board and that person gets a VTE and or dies and or JACO walks around, or Medicaid gets a whiff of that and they end up getting a VTE, holy cow, are you open for trouble. You're going to get fined, somebody's going to get fired, somebody's going to get dinged somewhere. Something's going to happen. And the worst of all, the bottom line is patient safety. You don't want that person dying, okay? You don't want them getting complications. So, early immobility. Think about that. Get them up and moving, right? Don't have somebody sitting in a chair all day. Every 2 hours, you've got to move position. That patient should be turning every 2 hours. If they can't move on by themselves, then you are responsible for moving them. If they refuse, you are responsible for giving them this complication in education. Like I said, you can lead a horse to water. You're responsible for giving them that information. They have to be able to understand what you're saying, so watch for people as English as a second language or as no language at all. Do you have to get an interpreter? So if they're not listening and not following your instructions, why not? If they're competent and you've given them the information appropriately, they can make a bad choice, get a blood clot, and die. That's their choice. But if for some reason you're not giving them that information appropriately, that's your responsibility. It falls on your license and your shoulder. It's your responsibility if you're going into nursing to follow through. I can't help it if you're too busy. That's not an excuse. So you need to make sure that patient's turned and moved every 2 hours. If they're up in a chair, they shouldn't be up in a chair more than 2 hours. Have them stand up, march in place, walk around, go to the bathroom. They should be changing position every 2 hours. So if you, in your practice where you work now, or you're a student, and you see that they've been sitting up in the same position all morning, you need to be doing something about it, right? I think that's about all I have to say about that, except for treatment, bed rest. You're going to see differences in here in the time length. You might see sooner. They're mobilizing people with blood clots much sooner. So it depends how bad the clot is. What's going on? What else is going on with the patient? I'm seeing people discharged with blood clots before this time period now. So it could be 5 to 7 days if it's significant. Yeah, Christian?
You wanna, once you know they have a blood clot, wouldn't you want to mobilize them so it doesn't break free though?
Moving them might break it free.
Yeah, so how is that safe?
Then they get an embolism though. So.
It's very possible. Depends on the risk factors. How big is the blood clot? What reason did the blood clot form? How quickly is the body breaking it down? This 5 to 7 days was based on how quickly the body starts breaking down a normal person with normal clotting factors, right? That's how long it takes the body to start breaking it down appropriately so that it's small enough and you've got an anticoagulant of some sort on board or something preventing further clots from forming. 5 to 7 days for it to get small enough and no other ones forming that person can start getting up and moving around. It's ultimately the physician's decision. Okay? when I worked in the ER, oh man, back in the early 200s, we had somebody came in with a blood clot. They, boom, bed rest, don't you dare move. If a tech accidentally got him up, and either I didn't tell them or they forgot, oh my gosh, I had a physician down my throat immediately. It's like, why did that patient move? Because if you're up walking around, you're contracting that calf muscle. So they did not want that at that time. Nowadays, I've seen patients up on the med-surg floors. They will put them on a heparin drip. They will follow their PTTs and INRs, get them appropriately anticoagulated through a heparin drip, and then they will switch them over to either Lovenox, that they can give themselves a shot at home, or Coumadin. If they're on Coumadin, then they have to watch their PTs, or partial thromboplastin times, and they have to go in and get blood tests for that to make sure that they're not too anticoagulated or not anticoagulated enough. So you got to go in for periodic blood tests for that, and then they send them home sooner. But it depends on the patient. What's wrong with them? Why did they get the blood clot? How quickly is it being broken down? How safe is it to have them go home? So that it just depends on the patient nowadays. And you'll see that heparin, all it does is keep more clots from forming. It's not going to break down the current clot. If you need to break down the current clot, then you got to go to thrombolytics like Alteplase. Alteplase, and usually what you're going to see is those are the types of patients that come to me from the ER. They come in with a cold blue extremity and extreme pain because it's an acute occlusion. And what they're usually doing is they go to OR right now, and a vascular surgeon goes and shoves this nice huge catheter in their groin, and it's usually they'll stick it in the right groin and then they'll thread it down into the left leg where the clot is, and they'll literally drip this Alteplase right on that clot. And it's usually arterial. And they will usually also have heparin dripping at the same time to prevent more clots from forming. Those types of patients have to be monitored. Usually if they have that sheath, then they have to go to the ICU. Yes?
Why do they go in the left to get to the right?
Just because of positioning, because they want to go, they're going into, so that they don't want to occlude that area any more than it already is. So they're going to stick a huge sheath in there and then thread the catheter, which is much smaller, to the other side. They don't want to occlude that area any more than it already is. But and then they're going to drip that Alteplase on it, because that Alteplase is a clot buster. It will actually break down the clot. Okay?
How do they keep from it breaking? Like if it breaks down, smaller pieces could go.
It's breaking down that clot and dissolving it.
Okay.
Okay, so is there a chance pieces could break off? Yes, but not it's
Don't they do,
low
like,
risk.
Screens too? Like, can't they? I've heard of that. Putting, yeah, like
They'll, especially with traumas or people that come in that are having frequent pulmonary emboli, if you have high risk factors, they'll do what's called a inferior vena cava umbrella. I still see that done, not as frequently as they used to. And I'm not sure why, if it's just because it's a mechanical thing and it works for so long, or, you know, they have to. I've never heard of one being yeah, I have seen one replaced. Not very often, maybe 1 in 30 years that I recall being replaced. But an inferior vena cava, does anybody know what a steamer looks like, those collapsible steamers for vegetables?
Yeah.
Well, flip it upside down like an umbrella. Yep. And it's got like little tiny holes in it. But it's all it is like an umbrella, and it's put right in the inferior vena cava to catch any clots from the lower extremities.
And then it's coated with some anticoagulant. Right?
Nowadays they should be. Anything artificial that they stick in your, like stents, when they do casts or opening up like the arteries in your kidneys or your heart or your brain, they're coated with anticoagulants so that you don't end up clotting. Sometimes the body looks at that, is this something foreign, do I need to clot around it? You know, it's an uneven part too in that vessel. But the good point, Matt. Thanks for bringing that up. So, I think that's all I have to say about that now. So that's an important topic. So remember, we're talking, holy cow, you guys are loud. Sorry, I'm just to the point where I'm not dripping anymore. Let's see. Where were we? We are on infection, right? Complications. These are complications of fractures, right? Hot dog. Love cutting things in half in between 2 days. Anyways, so you're going to have infection mostly with compound fractures, right? I talked about this on Tuesday about osteomyelitis, or an infection in that bone, how important that is, how long-term of an issue that it is. It can affect you lifelong. You have IV antibiotics, you have a slow healing process. It's a chronic condition, so it's not a good thing to have happen. And you can have that with traumas, compound fractures, docs doing surgery that for some reason, those orthopedic surgeons that poor technique, or somebody, you know, messed up and they get an infection in the bone. That's a lifelong issue. Do you have a question?
Yeah, I was just wondering if the whole problem is that because the infection moves, or is it just that because it's in the bone, it's just that much harder to get to?
Once it gets in the bones, it's almost like chronic. It's almost like getting, I think of it in relation to MRSA. Once you get it, you're always colonized with it, and then it can flare up the next time you get an infection. Something similar to that. So if you can relate it to that, it's just chronic. It's very hard to get rid of and deal with long term. Delayed or non-union, I think we talked about this a little bit already, but where you have prolonged healing of the bones beyond the usual time period, or no healing at all for one reason or another. You have risk factors are including for delayed union or non-union, could be like poor nutrition, alignment, infection, or necrosis. If it's not healing, you know, is it an alcoholic that's got poor nutrition, or you know, somebody that lives on the streets? Yes, my LA girls. Allison, what? Treatment, yes. Sorry, yeah, catch me on that stuff. Anemia, right? Because you don't have enough hemoglobin circulating. So think about what are the comorbidities? The elderly, so they not only do they run into anemia more often for multiple factors, but then what are their bones like? You know. So could be a lot of issues. It could be somebody that doesn't have good healing, and then it wasn't followed, or they didn't start their antibiotics in time, and then you ended up with necrotic tissue or infection because of that. Holy cow, does that run you into trouble? Yep. Any comorbidity, diabetes, heart failure, anything that's going to prevent healing. It could be just the physician that didn't do a good job of alignment. It could be somebody that didn't seek treatment early enough. Prolonged reduction time, you know, for whatever reason. You know, maybe they had other life-threatening injuries they had to be taken care of first. So now they have to deal with the complications of not taking care of, you know, putting this bone in alignment. You can have infection or necrosis not only for antibiotics, but what if there was an issue with circulation to it? You know, it could also get necrotic or infection because of that. Casted wrong, gave you that example, my granddaughter. A lot of times, if somebody isn't sedated or sitting quiet enough when they're casting, like if they're casting a lot of times, it could be a new resident that didn't do it right, or an intern. Got to make sure that if you're working on this hand wrist, that thumb is pointed upward rather than having it like this while they're trying to wrap it or put the cast on. You know, it could just be the technician's lack of experience. So you're looking at 6 weeks for healing. Is age is up there, right? Immunosuppression, think about that. Or how badly the bone's damaged. You know, that's the more damage you have, the more you've got to consider. The more you've got to consider how long it's going to heal, right? Treatment might be surgery, might have to be bone grafting or debriding. You know, if it's necrotic, or you go in and somebody had an open compound fracture and they were in a mud, dirt, you know, road grime, whatever, tree bark, for whatever got in there, they might have to kind of debride that out. Yeah, Matt, are you think? Oh, okay. So just think about that, the type of things that they have to deal with. Yes.
I'm thinking about the typhoon in the Philippines, how much this must be affecting those people.
Oh, huge. Well, and they talked about, they said people that had minor injuries are now running into major complications because the minor injuries were not addressed, right? So I'm sure you've seen a lot of this.
They had them on the news last night, and some doctors were rerouted from a trip to Mexico, the Philippines, and they were showing like they only had one little sheet to do. They're trying to cut 24 squares. They don't have enough medical supplies.
Sure.
They're giving them like one, like amoxicillin, or one like what is it? Antibacterial.
Some sort of antibiotic.
Yeah, one antibiotic. They could only give them one. Yeah, one dose. That's the best they can do.
I guess if that's what's keeping you alive. Thank you, Erica. All right. Anything else on, treatment. Oh, electrical bone stimulator. Anybody ever heard or used one of those? Know anybody? It's like a TENS unit. They'll put it on both sides of the fracture to stimulate the bone to grow faster and heal. Those osteoblasts. Remember, look at the in your outline for this section. There's a gazillion vocabulary. Make sure you look through those so that you know what those mean. Okay. So sometimes they'll use those. I have not actually seen one. I just know they exist. And reflex sympathetic dystrophy. It's that complex regional pain syndrome. I might have mentioned this a little bit before. It's a poorly understood condition. The signs and symptoms are the persistent pain and hyperesthesias, which is you touch their skin and it's like you just stabbed them. They're just hypersensitivity to any stimulus. They have swelling, changes in color, texture, temperature, and decreased motion. I had a colleague of mine that had that developed for her. I think I mentioned that already. For two reasons. She had knee replacements and developed that. So her foot, I think it was always feeling cold. And then she had an epidural and that screwed her up even more. And she had pain. And I remember she had a lot of swelling. Yeah, Allison.
But it says in the book that females in older age people are more at risk. Why is that?
Good question. And that's what I see. Because I I do see more females. Maybe it's the location of the sensors, because I see more men about Kevin's age that had the most pain for open heart surgery. And maybe it's in their chest area, because we don't have any explanation for that either. And we surmise, and there's no evidence to back it up, that there's just more sensors, nerve endings in that area for them at that age. So I don't have a good explanation for that. Same thing. But I do see it more often in women, that sympathetic dystrophy. So if somebody does find information on that, please share. Okay? So any of those things can occur. And it's not, and the problem is the treatment, there's not a whole heck of a lot you can do for it. They might do nerve blocks. They might try things like Neurontin or Lyrica that are meant for other reasons, but they also work for this. Don't you also see women have more, is it women that are more apt to have fibromyalgia? Do you see that too? So maybe it might be the same type, just the way the nerves are innervating. This colleague of mine, she actually had that nerve stimulator. She also had implanted. She had TENS unit. She also had implanted. It tried blocking the pain stimulus going to the brain so that she would feel less pain. And she had to pay for that out of her pocket. I think she had to go out of state to have it implanted. But it was within the United States. I remember that. It just wasn't done here. The docs didn't want to touch her. Trying to think of what else. There's other types of, we'll talk about it more, where they'll go in and do, for certain nerve related issues, they'll go in and literally cut the nerve. But I haven't seen it done for this.
Well,
Okay.
Sympathectomies.
Sympathectomies.
Really work.
Yeah.
It's,
Have you seen it done for this though?
yeah, and then I have seen them working in pain like I saw on TV, but
Okay.
people who get it done, usually, if we saw them, it didn't work. So.
Right, because, yeah. How, do you know what the stats were? Was quite a few of them coming back that had it done?
There wasn't very many of them that had it done.
That had it done, okay. Well, it's, you know.
I mean, not that we saw.
Okay.
Most of the people we saw, we just did the blocks.
The blocks, right, okay. Been there. But nope, I haven't. Luckily the blocks worked for me. And I went in before they got them contaminated with fungus. That was a drag. That clinic got shut down, the manufacturer.
And it was only
a small amount.
Small amount.
Yep. So think about what is the nursing care for fractures and think about prevention. Whenever, can you prevent fractures? You try, right? Once you get the fracture, how do I prevent complications? Try to get your brain in that mode, okay? So what is the nursing care and management? You've got pain. So always ask that patient to describe the pain. Remember how important it was in knowing that pain? What is the trend of that pain? Is it consistent with the problem, or is it giving you ideas of something else going on, right? Could it be that they're developing a VTE or a PE or a fat embolus? Are they the showering clots and now they're getting abdominal pain because you've clotted off their superior mesenteric artery to their bowel? Or are they starting to get TIA symptoms and I'm getting this the worst headache of my life? Could be that you're starting to use up all your clotting factors and now they're starting to bleed and now they're getting the worst headache of their life with a brain bleed instead of a brain clot. Got to start thinking that way. You got to start thinking about what are the possible complications and how do I prevent them, and how do I act on them. So pain is very important. Know what the trend, what are the characteristics of that pain? Is it normal for this situation, or do I have to start thinking about other things? All right? Use that pain scale. And if you can't use the pain scale, find some other way to measure it, right? Everybody's done a pain nursing care plan, right? Everybody's got a successfully passed pain nursing care plan, right? Okay. Otherwise, get somebody that has. All right. So impaired physical mobility, right? Are things barrier-free? Do they need assistive devices? Do they need a cane or a walker? Do you have a little old lady from World War II that's got, you know, maybe 2 feet wide with newspapers and magazines and all her tchotchkes and all the stuff that, well, I might need someday in my life, you know, up in her home, you know, and how am I going to fit, crutches through there? What other type of environment do they have at home that you're sending them back to? They got an alcoholic son that beats them up, or, you know, what is that environment, you know? Are they alone? And they shouldn't be, you know? Think about that stuff. Impaired tissue perfusion and neurovascular compromise, right? Remember those 5 P's. I can't shove that down your throat enough. How often should you be checking for that stuff? How often should you be checking for this? Every hour, every time you walk in that room, right? Eyeball it. They got a cast. They got that leg. How's that pain doing? Remember your pain reassessment, right? And what is their response to the trauma? That includes psychosocial. Yes, 102 that I would have failed. Do I check? Do I make sure that that little old fella that's got his dog at home and nobody taking care of it, or his parakeet or whatever? You know, I can't stress that enough. I mean, somebody, if they lose hope or they have a home situation, they're going to lose their home, you know, they might just give up. This is just one more thing on my plate that I can't handle no more. I just give up. And you'd be amazed, it doesn't matter what age, you can lose somebody very easily that just gives up at any age. And how does that impact their home? Do they have somebody taking care of the bills for them? Do you have to send them to extended care facility and tell them this is just for a short time? Or do you have to get somebody involved in managed care to help them cope with, I can't go back home. I have to go to extended care for life, for the rest of my life. That's a huge impact. You take somebody's home away from them, you take away their ability to drive, they kind of want to curl up and die. That's a huge impact psychologically. So think health promotion, right? You want to maintain good bone health. Got milk? Yeah, that commercial is there for a reason. You've got to have the calcium intake when you're young so that once you hit menopause, you're kind of up a creek. Think about weight-bearing exercises, avoiding obesity and losing your balance. Exercise and toning, it just becomes harder to move, okay? So these are huge health promotion options that you're looking at. Think about any community impact that you can have. You are a population that is going to be really strongly needed out in the community. So yeah, some of you are ER junkies, adrenaline junkies, you want to work the ER or wherever, ICUs, that's fine. But you may or may not be there for your entire lifespan for the nursing career. There's going to be a huge need out in the community. These are huge impacting options that you're going to help to prevent people from getting breaks, fractures, and or complications. Yeah. Okay? So huge, nursing health promotion. Think about your churches, your community centers, you know? Give back to the community once you get out of debt. All right? It will happen someday. I promise. What else? Nursing diagnoses. Number 1. Pain's a good one. Yep. What else? Impaired mobility should be up there, you betcha. Risk for infection, you betcha. What else?
Risk for disturbed sensory perception.
Risk for disturbed sensory perception, psychologically, physically? Physically, okay. So that has to do with your sensory neurovascular dysfunction. But also, you take an older person with a neck, other fracture of their pelvis, and you pull them out of their normal environment and stick them in a hospital and give them drugs. They're going to have a psychological drug and stress-induced psychosis, maybe, right?
Depending on where it is, could be risk for fall.
Sure, absolutely. Right? What else? I think we've got all of them in there, right? Did we talk about all those?
What coping?
Coping's huge. Coping's huge. Very good. I like that one. See, I would have failed 102. I'm going to borrow your pen. That's a good one. Thank you. Oh, he's got a crushed phone. Oh, I hate when that happens. Bummer. You got to get on that commercial. Take my phone, please.
That's right.
So, home care, cast care, how to shower, how to monitor the skin. Do I have to put a plastic bag on it, wrap some duct tape around it? I don't. Whatever they do. You can't get the calves wet. Remember, either it's going to stink or dissolve. Yes.
I was in Walgreens last week looking for a heating pad, and there is this product where it shows this very excited, very happy woman with like a cast on her arm, and it's this like foam ring that goes around, and then this plastic sleeve, and she's like sitting on the edge of the bathtub getting ready to get in there. So they do make a standard
Like
product.
a sleeve? Oh, how about that?
Yeah.
And it's a foam ring. What is it? Kind of just, the foam ring is right up against the skin?
Yep.
Oh.
And then
It's like a gasket.
yep,
Like a gasket. There you go.
It's like a little, it was
Maybe it's a
weird.
mechanic that's now a gazillionaire, right?
He broke his arm with a carpet.
I'm going to make $1 million off of this. Probably more. Excellent idea. So it's at Walgreens. There you go. Now you know. Your community intervention. So you got to check the edges around the cast, right? You want to monitor that skin. Because a lot of times, I had my son, he was in a pica cast. It was like, went around his whole torso here and then went down the leg. So you had to be really careful in that poor little kid's groin area, or when he went to bend, that any edge of that cast, not only the circulation within, but also that the edges weren't getting raw. Sometimes I've seen people use like mole sheepskin or moleskin or something to put on the edge. But just be careful, you know, because sometimes the edges can be a little rough. Sometimes you can ask them to fix, you know, help with that a little bit. But watch for pressure and friction, okay? Think about casts that go down into the extremities, right? Be very careful for circulation. Make sure you follow the doc for weight bearing. When am I supposed to walk on this? When not? You weight bear too soon, you're going to cause damage, and you know, your hands and your feet are very precious extremities. Once they're gone, they're gone. So if you walk on it too soon, it's not going to heal right, and you're SOL. So make sure that they understand the importance of not weight bearing any sooner than what they're told. Give that bone time to heal, okay? Range of motion to the unaffected joints, right? So if I've got a broken wrist, you know, you can still do the fingers, you can still do the elbow, whatever. Make sure that movement's going around. You keep that mobility. You don't want to end up having a frozen shoulder or something just because you're afraid to move that arm. Remember, don't forget to elevate to decrease swelling and pain. What are the things that you have to, when does discharge planning start? On admission. I want that so hardwired in your brain that you don't even think about it. You just do it. Because they're not at this point. They're just task-oriented. I know you're task-oriented right now because you're so focused on, oh my gosh, I got to know how to do a straight cath. And I haven't had that chance, but you know what? You got to look at the bigger picture. Are they going to be able to go back to their original environment? What types of things do I need to make them safe in that environment? Okay? Do they need a nice elevated toilet seat? All right, they don't have it. How do I get it for them? What community resources do we need to tap into to have that safe environment, or do we have to go through the government and start looking at other things? Do they have to go to extended care for a while? What do they need to go to get through the system as fast and safely as possible and get them to their optimum level of functioning in the optimum safe environment, right? Does that make sense? Okay. Do they need a wheelchair? Do they need a wheeled walker or whatever? Onward, amputations. You guys can read this. I don't have to read it to you. This is 40, what? 48? What happened to 47? Holy cow. All right. All right. C'est la vie. Gosh, I gotta borrow your pen again. Sorry, Kevin.
No problem.
48. So, amputations, a partial or total removal of a body part resulting from traumatic event or a chronic condition. This is a nice, good picture. For those of you that do really well with pictures, this gives you the whole idea. You got stump care. You got to elevate that stump for the first 24 hours. After that, think about that, especially with an above-the-knee amputation. What do you think that's going to do after about 24 hours? What do you think? Not having that weight bearing and stretching that flexor muscle, what do you think that's going to want to do? It's going to want to contract. Yeah, that muscle is going to want to flex, right? So you need to keep that stretched out and down so it will fit into a prosthesis and work. You've seen people that have that are paralyzed, you know, divers. What happens to that muscle? It gets atrophied, right? Doesn't want to work. But immediately after, what's going to happen is that it's going to want to pull right up. It's going to want to do this. So think about, what do I have to do to maintain that extension? Keep that extremity stretched out until we can get it fixed up for a prosthesis. You're going to want to make sure you wrap that. See how that's got a nice kind of a cone shape to it? You want to make sure that that dressing's on there to help facilitate that forming so that it'll fit into a prosthesis. Okay? They might want to, and think about that, if they chopped it right off, if it was a traumatic amputation, like that guy I told you that got crushed, think about the bone. Can you imagine coming right down on your bone all the time, how much that would hurt? So they probably quite often will go back. They might have to revise it later, or they might do it during that initial surgery, but they might cut that bone a little bit shorter and actually bring a flap of skin around so that your suture is not right on the tip, so that the suture is more up here, either anterior or posterior. So you're kind of wrapping that area so you got regular skin that you're putting that pressure on. Does that make sense? You know, a lot less painful. You know, if you don't have an incision that you're putting that pressure on, less of a chance of that friction and pressure causing skin breakdown. So you kind of want that flap in there. It works really well. It just depends on the person and the type of surgery and why they did the amputation. because it could be a traumatic amputation. It could be somebody with, my uncle, I know the weirdest people. My uncle, God rest his soul, was a smoker, World War II, soldier in Germany in the winter with boots, and developed Burgess disease, so poor circulation in the extremities. So they didn't get to change their socks every day. They marched for days and days and days in this ice and snow, ended up losing one leg right at the end of the war in 45, and then developed diabetes on top of all this, and heart failure because of the diabetes and the genetics, that he had poor genetics. So he ended up getting the other leg cut off. Where was I going with this? Oh, okay, so chronic conditions. Here's an example of chronic conditions that can lead you to having amputations. But I'll tell you, that guy hopped in his prosthesis and eventually both, and he'd walk around, man, you couldn't keep that guy down for nothing. The heart failure killed him in the end. So think about that with amputations. You've got to find a way. Nowadays, usually in acute care settings, they get physical therapy, occupational therapy involved right away, because you've got to keep this stretched out. How else do you think you could keep somebody stretched out? Range of motion. Okay. What else? Yes, Sarah.
I don't think they do that anymore. Probably not. Traction, I was thinking, just as we talked about it, but that would work for them.
No, I'm trying to. No, I'm not. I'm not seeing that. Not seeing that. What else could you do? Get out of bed. Okay. So you get out of bed. How would that stretch that leg? How would that stretch that extremity? How would you keep that straight by getting out of bed? Stand up. So you're going to do some range of motion on that. That would include range. What else could you do? How else could you stretch that out?
Strap it to the other leg.
Strap it to the. Interesting.
I didn't even think
That's a good thought. Strap a belt around it, you know, and get somebody up and walking. Of course, that would be kind of weird because you'd be. No, that's Gundam style. Not. That was almost obscene. Yeah, I don't know how that would work. Your whole pelvis would be going at the same time. You know, and people with a broken leg, they'll do that. They'll swing through. Yeah. So keep it straight. So that's a possibility. What else could you do? What if they're in bed for a while?
Put on a compression. Like, would you put that on?
How would you stretch that out? How would you extend?
Yeah.
Say again?
Because they have to lay on their stomach for a certain period of time.
Very good. Prone. Lay over on your belly for a while.
Change position.
Yeah. Well, change positions, but you got to be specific. Because laying on your side, you're still going to flex, right? And I didn't hear that, or we went with that. Sorry. But yeah, prone. And think if you're out in a podunk hospital where they don't have physical therapy out there really aggressively working with them, flip them over. But that's going to be more probably, that first 24 hours you want to elevate it for the swelling, right? You want to, and you might even use ice and stuff. You can use ice ongoing, right, for even pain management. But after that, you want to get that stretched out as much as possible. What are you thinking, Kevin?
that's hour 25.
Why not? Make sure they're breathing. Prevent contracture at the joint above the amputation. Phantom limb pain. I find that people, and I think I mentioned this under the pain section, they remember that brain remembers the effect that they had prior to that limb being removed. And if it was pain, it seems like that's what they're going to remember. My leg hurts even though it's gone. So they'll do that mirror type therapy and stuff like that to help retrain the brain. They might use that stuff like Neurontin or Lyrica to try to help with that. The type of regular analgesics that you can use. immediately post-op, you know, you're going to use your stronger drugs, right? If you're doing an amputation, right, in the hospital, you can monitor their breathing. You can throw pulse ox on them. Then you wean them down for home. Discourage semi-foulers. Think about that. You don't want to have them sitting in a wheelchair all day long, right? You need to make sure that they're moving every couple hours. Prevent further complications, right? You want to watch that circulation there. Did they, or bleeding? Did they miss a small artery or vein or something, and something's leaking into the tissue and you end up with this massive bruising? Yes, my LA friend. It's not Allison, it's L.
Yeah, Lindsay.
Lindsay,
That
okay.
actually just happened to a patient of ours we had on Sunday. He was about, I think he was maybe 2 weeks post-op from a left VTE.
Okay.
Saturday morning started complaining of a lot of pain at the stump. So the nurse kept looking at it. A couple hours in, it just kept swelling, and she's like, something's not right. They paged the surgeon multiple times. When he finally came, she said his stump was like 3 times the size it was that morning. And so the surgeon, he's like, well, I want to try something. He pops 2 staples out, digs his hand in there, and blood is just just a volcano coming out of there. He had a massive hematoma on the bottom of his stump.
So it goes, you know,
So he
blood
had
goes.
surgery.
Yep, absolutely. Was a venous bleed?
I don't know. We
Okay.
transferred him up to PACU at like 7:20, and we left at 7:30.
Okay.
So I
Be
never really
interesting.
found out what happened.
Okay. So a small vessel bleed. You said it was 2 weeks?
It was about 2 weeks.
2 weeks. So that's kind of a ways out, right? Blood wants to go dependent, right? So it's going to drain down. So she said it was posterior, right? Maybe it was a stitch that broke when they sutured the vessel, and it was a friable area that just broke loose. You know, maybe he was doing some aggressive therapy or something and it popped. Could be anything. Could have been a small venous that took a while and then all of a sudden, or it could have been a bleed that was something that was bleeding, that the initial swelling had kind of tamponaded it off, you know, squeezed it so tight, and then as the swelling went down and the tissue was healing, popped it open and it started leaking spontaneous. Could have been any of those. Could have been any of those. So pay attention. That's a perfect picture, Lindsay. Thank you. So that could be a week, 2 weeks out. So pay attention. All right. So you're going to watch for comfort, mobility, circulation, right? You're going to assess for skin breakdown, make sure they move. You're going to watch that stump, especially as they're starting rehab, if you're working in a rehab area, in an extended care where they're starting to learn to use the prosthesis. Watch to make sure that you don't end up with a skin ulcer. What's that going to do to their rehab if they can't put that prosthesis on, right? Be careful. Remember, alcohol dries, and you don't want it too soft, because you want it to be kind of in between. Because I don't know if you actually want a callus, but you just want you know, strong tissue that's not going to be susceptible to friction. Encourage client to wear his prosthesis when he gets it up all day to prevent that stump swelling. Because once it swells, like if you take it off for a little while, it's going to be hard to put it back on. Yes?
I was just wondering, because you have above the knee and you have below the knee,
Uh-huh.
but on it says discourage with above the knee. Is there anything else that's different in the care between below and above?
Well, when you have it above the knee, you're more apt to have that flexion happen much faster than below the knee. You have much more mobility and functionality below the knee. So it just depends how much of the tissue is taken off. But your contractures much quicker with above the knee, because once that knee's gone. Okay. All right. Speed. Causes. Peripheral vascular disease or peripheral arterial disease can be a major cause. You have that poor circulation going to the tissue, not getting that oxygen to the tissue, right? Think of your chronic comorbidities like diabetes, as Kevin mentioned, chronic high blood pressure, hypertension, smoking. How well does oxygen get to your tissues with smoking? All right? That can be chronic or acute. Trauma is usually the major cause of upper extremity amputation. Think about other things causing trauma like frostbite, burns, or being electrocuted. I've seen electrocution where it's literally blown off parts of fingers and hands, parts of the feet, because you usually have an entrance and an exit wound with electrocution. I had a young nurse, she's probably in her late 30s now. She was working with sailboats out on the shoreline, and the mast hit a power line, and she got electrocuted. She had part of her neck taken out. She lost her thumb. I think it blew out her hand, or it went through her hand and blew out her neck. I forget. But she lost her whole thumb. They ended up putting her toe, her big toe, up here so that she could have dexterity. Yeah, I think that's the way it went. I can't remember. But she was lucky to be alive. She had a trach for a while. She had some severe burns. She ended up being the manager of the burn unit for, I don't know, 5 years, 10 years. But she came in as a burn patient, as a young college student, and that made her want to be a nurse because of the care that the burn nurses gave her. So, and she's very compassionate, very awesome lady. Underlying causes can be acute or chronic. It's interruption in the blood flow, right? Your goals are going to be to alleviate the symptoms. If you're bleeding or there's peripheral vascular disease, you got to watch for pain or sores. You want to maintain a healthy tissue. If it's open, it's called that guillotine. That you're going to see that more often for infection. They might want to do that short term, and then later go back and close it up. But they may want to have, if they do a guillotine, they might have to watch for infection. That might be a reason why they do it. But that, usually I'm seeing them, they eventually want to do that flap. You want to basically have increased functional outcome. That's your goal, all right? And for the site healing, very important, watch for that stump to heal, right? You're going to assess the circulation, your 5 Ps, all that good stuff. Maintain. Thank you. MTN is maintain.
Yeah, can you explain to me? I mean, I know what a guillotine is, so I'm just thinking.
Chop. Chop straight off. You're going to see all the fascia. You're going to see the muscles. You're going to see the bone. They're only going to do that short term, and they're going to wrap it. They're going to, you'll see. Like this, you'll have your bone right in the middle. It's just chopped right off. Think about a CAT scan, slice of a CAT scan. It's going to be chopped right off, and they're going to monitor this. This will be wrapped, packed, and wrapped. But they're monitoring this. They're watching for necrosis here, and I've only heard of that usually with infection related, where they know that they've got to go back and reassess. Okay, it's just guillotine, chopping. No. It's usually for infection monitoring. They've had an infection. Think of the strep bug. What is it called? Gas gangrene. Say again? No. Gosh, come on. It's strep. It's strep. It eats your tissue. Necrotizing fasciitis. There you go. Boom. Chop it off. They're going to monitor it. Good job. Good job. Necrotizing fasciitis can kill you really fast. So they're going to, you know, that's an example where I could see that they would do this because it's short term. They're going to have to go in and close that because what they're going to do is they're going to want to cut this bone shorter and then take this tissue and wrap it. Does that make sense? Okay. Let me see what else. What slide are we on here? 48, 49. Do I have rigid compression on there anywhere? Yes. You're going to want to do that wrap. That's going. Usually, I've got a picture of it. I don't know if it's in your lab manual or you can Google it. Where they're going to start. They might bring one down, but they're going to wrap it like a figure 8. And it's going to be firm and it's going to be compression. So you might have a dressing on the very end for a little while. If you've got a guillotine, you're going to have compression on there anyways. And they just might use foam tape for short term. But once you have that flap and that stump, you're going to do that figure 8. And it's going to be a figure 8 because it's going to pull and keep it from swelling, okay, to make that cone shape. There should be pictures. If you can't find it, let me know and I'll find you one. There's a picture in the book. There you go. Thank you, Sheena. What page? 1329. 1329. There you go. So you want to prevent infection and minimize edema to get them up. Stand them up very soon after surgery with a temporary prosthesis until they get a permanent one done, because you don't want them to lose that sense of balance, especially above the knee. I mean, you can lose part of your foot and still have big issues with sense of balance. It's very important. And some people will get a permanent prosthesis implanted, usually younger people. You want the stump that's wrapped, ace wrapped to allow that cone shape. Prevent edema. It's applied from distal to proximal. Talked about not elevating after the first 24 hours. You're going to prone them. Flexor muscles are stronger than extensor muscles. So that's why you're so prone to flex. And once you start getting that contracture, it's much harder to fit the prosthesis and get it to function appropriately. So you need physical therapy and occupational therapy if you can. Your complications involve infection, right? You got delayed healing. If the circulation isn't good, it's going to take much longer to heal. They can end up with chronic stump pain. That's why they'll cut that bone shorter. You want that flap if you can. You don't want that pressure from the bone right on the edge, right? Let's see, you can have that phantom pain. Remember, it's very real, very difficult to treat with narcotics. They usually need Neurontin or Lyrica might help. Might. Don't forget about contractures, okay? Especially with above the knee amputations. Range of motion. Avoid sitting for prolonged periods. Holy cow. Think of nursing diagnosis, page 1331. Physical, psychosocial. You got pain, grief, altered body image, mobility issues, risk for infection, and skin integrity. Coping. Yes, get that one in there. Onward, repetitive use injuries. Carpal tunnel syndrome. That's compression of the median nerve in the wrist. Symptoms are numbness and tingling of the thumb, index finger, pain interfering with sleep because of the positioning, and the weakness of the hand. And when they do surgery, they're just going to make a bigger tunnel. Sometimes you'll get to wear that nice splint at night. All right. Bursitis. Where we got here? What am I missing? Is it on there? Bursitis? Okay. Inflammation of the bursa. Enclosed sac between your muscles. Tendons, especially in the shoulder, hip, knee, and elbow. Symptoms involve joint is tender, hot, red, swollen with pain upon flexion of the joint. Both of my surgeries and my shoulders, when they went in there, they just sucked out all the bursa because it was just beet red and inflamed all the time. So itis, inflammation, right? Collaborative pain care for all these types of tissue injuries are pain relief, increasing mobility. You're going to use NSAIDs to decrease the inflammation, steroid injections into the area. You can have that done usually twice a year. Do you know of anything else, Matt? And it feels really good. You just want to get your claws on the ceiling and scream. Some people have to be sedated. To me, that's an extra injection and somebody to drive me home. So treatment is conservative. You can do immobilize with splinting, a sling for a shoulder. Remember, rest ice. Sometimes you might alternate the heat and the ice. Remember, you're going to do a chest. You're going to not a chest. You're going to do an X-ray to rule out bone injury, right? If you need surgery, you're going to do incision to remove the inflamed bursa or make a tunnel bigger for the carpal tunnel, right? If you're going to do some sort of invasive surgery. You're going to look at acute pain and impaired physical mobility. Because if they're taken out, if they're messing with your shoulder or down here, it's real common to get what's called a frozen shoulder. So you want to get them, you want to get that swelling down as quickly as possible if you're doing a surgical intervention, and get that joint moving as quickly as you can, as well as you can, because the longer you get out from the intervention, the less chance of improving mobility over a long period of time. Nursing care. Pain relief, increased mobility, right? Anything else?
With the increased mobility, how do you put that together with resting and avoiding activity?
Time frame. Initially you want to rest, and it depends if you're in conservative treatment. Initially with the injury, they're going to rest it, give it time. NSAIDs, like when you have a tendonitis, you can't go back to your swinging a hammer every 50 million times a day. They might say you got to take a week off, rest it, right? Or it might be longer. Could be a month, might be 6 weeks. But you've got to give that inflammation in that area, what is it called, hammer elbow? Or tennis elbow? I think tennis on the top and elbow and hammers on the bottom. It's one or the other. But you can affect both areas. You've got to rest it. You can't go back to that repetitive use all the time. You got to give it a period of time to rest with NSAIDs to take down the inflammation, give the time for that tendon to heal.
So then when would you increase the mobility then? Because you'd be back to that repetitive use.
Eventually, hopefully. They might tell you find a different job. Okay. If you keep going back to the repetitive use and you keep getting the same injury from that type of work, you got to find a different job. If you can find a way to work yourself into it, and it was just something that I did, like I was working a lot of overtime, and that's what got me in the trouble. Well, then I'll just do it, but I won't do overtime. Okay, and you can stay in that, and you might end up having the same problem down the line, but at least you can work a little bit longer.
So do you vary the mobility to change the?
With the injury, you got to rest it initially. Then you work with the correct drugs to correct the problem, and then you start mobility, range of motion. Range of motion is usually first before strength, and then you start strengthening the area, okay? Because especially once you think of surgery, you've got to give that swell, I don't know, 2-3 days of swelling to go down. They'll usually give you a cryo cuff. you know, with ice, and I put mine on much longer than I was supposed to. Or have that sub-Q, that on-Q pump that I told you guys about, the best things since sliced bread, where you had lidocaine or some sort of a local anesthetic dripping in there for 5 days. I took mine for the max. And, you know, I was, you know, so then I could start gentle range of motion, because otherwise you end up with a frozen shoulder. And I think I've got pretty good range with that. So it just depends. You know, you've got to think about that 24, 48 hours after surgery, and then they give you mild range of motion exercises, and as it heals, then you start strengthening. Okay? Did I answer your question?
Kind of.
Kind of? Okay, what else do you need clarified?
Well, it says to increase the mobility, but that's what caused the problem.
Mobility could be range,
Okay.
not necessarily the repetitive.
So
Yeah.
varied mobility.
Yes. Is that more clear?
Yes.
Okay. Okay, impaired mobility, NSAIDs, treatment, X-ray, okay, surgery, okay, home care, rehab, avoid activities that increase the risk of redeveloping the injury. I think I already mentioned that, okay. Onward, osteoarthritis, degenerative disorders, big clue up here. Degenerative means what? Gets worse with time, right? And as it's getting worse, it's not going to get better. It just gradually gets worse. There's no going back at this point. Maybe stem cells will do something with that. I don't know. But, so osteoarthritis, aka degenerative joint disease, it's the most common form of arthritis. Gosh, what happened here? Loss of articular cartilage and hypertrophy of the bones at the articular margins, okay, where you're bending. You know, where the things fit, where the knee bone connects to the, you know, elbow bone connects to the, you know, arm bone, I don't know. Arm bone connects to the shoulder, I don't know, something like that. Anyways, where they come together, articulate. All right, so Chapter 40. Most common form, males more often than females until menopause, or approximately age 55-ish. Then the incidence is twice as high in females, just because of that calcium deal. All right? Do I have risk factors up there? I do? Yes. Age, so thanks. If you're unfortunate enough to be have it in your genetics to have issues, you run into it younger. I've been on arthritis medications for well over 20 years, and I'm maxed out on what I can take other than chemo drugs. Don't want to go there. Excessive weight, especially in the hip or knee. Think about that extra weight on your joints, and your joints say, man, lose some weight there. Take some weight off me. I'll live longer. Inactivity, think about strenuous or repetitive exercise like sports. You know, think about your tennis players, your football players, and you know, all that takes runners. What does that do to your joints, man? Just kills you. Hormonal factors. So your pathophys involves that cartilage lining the joint degenerates or falls apart. It's just basically wear and tear. They're not sure. They're guessing autoimmune. Joint space narrows because of the cartilage is gone. You can also develop bone spurs. Remember those osteophytes a lot of times are what builds into those spurs. They form along the edges of the bones. They cause pain and limit mobility. You'll see spurs most often in the fingers. I get them in my shoulder along the articulating edges. You can get them in your spine. You can get them anywhere. Your symptoms onset is gradual and slowly progressive. It is pain and stiffness in one or more joints. And your nursing diagnosis would be, you know, a self-care deficit. I can't make a fist. If I don't take my drugs, I can't make a fist. I can't pull somebody up in bed. I can't even hold a coffee cup. The pain possibly can be referred to other areas. It's just that stiffness. It just depends how far it radiates. You could have decreased range of motion, and you'll hear sometimes, oh gosh, I remember sometimes helping a little old lady turn in bed, and I'll grab their wrist right here, and you hear that grinding of the bones. It's called crepitus. It's just a really creepy feeling. So that's another term where you might hear that term crepitus. Remember, you hear it in, or at least my students know, crepitus can be subacute emphysema or air under the tissue when you have a leak in your lung tissue, and it feels like Rice Krispies when you touch the chest. That's another crepitus term. You can have bony overgrowth that causes joint enlargement. You see people with what is the name of that guy? He's a famous actor in. Say again, who? Elephant Man? I don't know. I don't know. I think about, did anybody see that Snow Dog movie? The guy that ended up being the father of the African American gentleman. I think he was a famous dentist or somebody. I can't remember. Shoot, if you didn't see it, you won't know what I mean. He had arthritis so bad his hands were just terribly deformed. He kind of walked around like this. That rheumatoids more often, but my 90-year-old aunt has joints about this big from osteoarthritis. Yeah. So, collaborative care. You want to relieve the pain. The pain, think about people that want to shake their hands, you know. You want to be able to complete your activities of daily living, you know, doing household chores. You want to hopefully try to maintain function and mobility as long as possible. So when you're first starting out, think about the medications that you can use. Remember, this is a chronic condition. Do you have swelling and inflammation? Yes. However, it might start mildly, so start mildly. Tylenol is strictly a painkiller, right? Is it going to do anything for swelling? No. However, things are going to get worse. If you can control it, this is one of those things where it kind of messes with your brain, but when you're working with a chronic condition like this, initially it might just be a painkiller because they're eventually going to get maxed out and there's nothing you can do for them. So just try. Will Tylenol work for now? Maybe it'll work for a year or two. Yes?
My patient this week at the hospital, elderly woman, has had osteoarthritis in her back for however many years, and so she's always taken aspirin. Well, now she has a GI bleed because she's taken the aspirin for so many years for her back. So she kind of
oops,
screwed herself.
well, for so many years, but for so many years. And maybe she could have caught that GI bleed a little bit sooner by paying attention to the pain in her gut, right? And then switched over to something else. But aspirin is a salicylate, you know. You have anti-inflammatory plus pain control. So it, you know, might work. But you have to look at other, you know, as her other risk factors are increasing, you have to look at. So she's probably going to have to shy away from NSAIDs altogether, right? But you can try this. Maybe they'll have to do something and watch her. What can they do for her permanently? Are they going to cauterize that GI bleed? Is it something they have to watch for? Was she doing something else that also affected it? So they have to weigh those risks and benefits of what they can do for that arthritis long term now that she can't take the aspirin. So she's past. They might try Tylenol for a while, just for pain control versus any anti-inflammatory effects. But try that for a while until at least that gut heals up, right? And then they're going to have to look at what else can they do. They might try paraffin wax treatments. You know, if it's just her hands that are bothered, but she said it was her back. So maybe they might try other things, physical therapy for a while, suck in the gut, tuck in the butt type thing, you know. But physical therapy, strengthening that core, will help. And it's, a lot of that is staying consistent with that. All the physical therapists in town know me for Spectrum Health. I have to go in for that Gibbs slap. You're supposed to be doing X, Y, Z, remember? So I'm non-compliant. So I just need that reinforcement of this is what you're supposed to be doing. So that's what, you can start with Tylenol, then you have to go to the NSAIDs. And then you end up with steroids, but that accelerates cartilage destruction, and that's why they'll only do that injection maybe a couple times a year. In your back, they might do it. You can only have it so often. So it just depends. So conservative treatment is that strengthen the area around the area of injury, because you can't prevent the degenerative process, but you can strengthen the muscles around it to support it, right? So think about it that way. Do they need help with ambulation, canes or walkers? Weight loss, analgesics, anti-inflammatory meds. Then if you have to go in for surgery, then you're talking about arthroscopy, arthroplasty. They might have to have a total joint replacement. Might have that nice stay at Blodgett there, where they do all that bone stuff. You'll see a total joint replacement, total hip replacements, or a THR. You can do that with the knees. It can be done for the shoulders. I'm avoiding that. Sometimes they'll do it with the elbows. Knees are more common than hips. They'll talk about more rehab on that when you go into your next class too. So complementary therapies that you can run into are the bioelectromagnetic therapy that supports the knees. That's like the magnets, copper bracelets, things like that. Hang on a minute. Don't go there yet. Elimination of nightshades or family foods. That's like potatoes, tomatoes. Is it on that last slide? Sorry, my bad. Peppers, eggplant, tobacco. You end up, oh gosh, what is it? It somehow involves alkaloids and calcium bone loss, and I don't know all the information behind those foods. Think about the nutritional supplements that you need, glucosamine and chondroitin if you can tolerate it. There's herbal therapies and vitamins. If anybody's got any other suggestions, we'll take it. You can do osteopathic manipulation to improve range of motion sometimes. And don't forget yoga. Nursing care, promote comfort, give their drugs, medications, warm mattress pad to keep the joints more mobile, but be careful that they don't fall asleep with them. Maintain mobility. My mom went to do the warm water at the YMCA. She took classes there. Assist with adaptation of lifestyle. They might need help at home. Remember gripper slippers to keep them from slipping. Anybody ever watch, I think I told you this about, what's the name of that? Clint Eastwood, Gran Torino, where the daughter-in-law walked in with a big phone and a gripper thing. This will make it easier for you to grab things. You see him growl, just like my dad. So they might need help with that, and they might need a little bit of acceptance and time to think about, yeah, that's really what they need, other than 20 years too soon for Clint Eastwood. So our nursing diagnoses include chronic pain, right? Impaired physical mobility. Think about those little old ladies. Now, let's not go shopping at Shipshawana unless you really want a wheelchair. My 93-year-old aunt, I cannot twist her arm enough. She will not take a wheelchair. She just won't go to certain things. but at least she's got the brains to know that I've got to return from however far I walk to. All right? Some people don't think that way. And then they end up getting somewhere and they can't get back. Self-care deficit. You know, do they need a long-term care facility and the coping skills that they need to deal with that? Onward to low back pain. Hope you went potty before we started. I was hoping for a break here. Low back pain was most often due to strain of muscles and tendons of the back caused by abnormal stress or overuse. You need to rule out degenerative disc disease and herniated intervertebral disc. You'll find some people call it a slip disc, a ruptured disc, herniated, which is a herniated nucleus pulposus. You'll find that over 90% of people will have complaint of back pain at some time in their life. Pathophys, it varies with the cause. Local pain can be caused by compression or irritation of the sensory nerve. Might be associated with disc disease or arthritis. Just think as that arthritic joint increases in size, it might be pinching on a nerve or on space that is needed by the disc. Okay, so it's going to start bulging that disc. You can have radicular pain with a herniated disc. And that what happens with that is that it pinches that nerve. Well, how far does that nerve go? How far does that nerve innervate? I'm pinching on a nerve somewhere between L4 and L5 and between L5 and S1. What type of things does that affect? I have to remember to suck in my gut and tuck in my butt so my toes don't go numb. When somebody has lower back pain, what else is in that part of your body that you got to pay attention to that it can affect? Urinary and your bowels. Am I going to be a happy camper if I've got to wear a diaper? No. So lower back pain is something to pay attention to.
Yeah.
Yes.
Does radicular pain mean that it radiates?
Yeah, it's like it may radiate or that's going to show up somewhere down the line from that nerve. I don't sometimes I have pain that'll wrap around and go all the way down my leg. Sometimes it's just I feel numbness in my toe.
Yeah. A few more slides, you have a dermatome there.
Okay, there you go. It'll show that. Okay. You can have it aggravated by movement. Could be coughing or sitting, just position. Muscle spasm you can have, the pain can be dull and it can be accompanied by normal posture. If I got a really bad back spasm, you might see me walking like this or something, I don't know. But muscle, think about muscle spasm, it's going to keep you from, your normal, I'm not going to be jogging in a marathon, right? Although they probably do. But I'm talking chronic, right? Clinical manifestations, mild discomfort to chronic debilitating. There's a box in your book that gives you some good information on that. You can have alteration in gait, neural involvement, loss of bowel and bladder function, and varying degrees of pain. Your diagnostic tests are conservative treatment for approximately 4 weeks. They might have you up walking around. Limit your lifting to less than 5 or 10 pounds. Don't pick up your kids or your grandkids, things like that, okay? Don't pick up that 50-pound bag of dog food. X-rays, remember X-rays show bone, not soft tissue damage, right? You could see a compression fracture, congenital problems. Think about how quickly somebody might tolerate a set of X-rays versus a CAT scan. They can do like in 5 minutes so they can determine a bony structure. MRI is going to take longer, but it's going to show soft tissue injury along with that. But MRIs take usually about 30 minutes. Meds, think about NSAIDs. Pain clinic for epidural steroid injections or adjuvant meds are like muscle relaxants. They may or may not help. They'll help with muscle spasm, or like with an acute flare-up. It might help. I avoid them because they put me to sleep. You try and stay away from narcotics unless it's an acute that is just totally debilitating, because it's basically a Band-Aid approach. I'm talking, yes, if it's a trauma you might need it short term, but I'm talking like if I have a flare-up, I'm not going to take narcotics. They might, if you go in to get a pain shot because you can't move or walk, it's just, you know, they might give you a shot and send you home with a 6-pack of Vicodin, but that's just short term. It's just a Band-Aid. It doesn't fix the problem. Does that make sense? Okay. It's just a short-term fix. So ongoing, I'm not going to take Vicodin every day because my toe's going numb or because I have a little bit of back pain. There are people that live on Vicodin. Okay? But how good is that going to help when that injury flares up even more? They're going to need that baseline drug, plus they're going to need something stronger, like if they fell down some steps or something. Conservative treatment, limited rest and early mobilization. Think about somebody with back pain. They're going to lie down initially. You're going to have a low follower, so your knees are going to be bent up, maybe a pillow underneath the knees. Remember when you do your abdominal assessment, how you had that? You can use the knee gauge on the hospital bed or throw a pillow under their knees. If they're laying on their side, they might want a pillow between the knees to maintain alignment of the pelvis. Because if I'm stretching my trochanter, I'm usually in a lot of pain. You'd have to shoot me to keep me in bed in the hospital. Knock me out. Because I'm going to be that person on that light. Every 4 hours, give me my drugs. Where are we? Back pain, knee gouge. Okay. Application of heat and ice. Thin and flat. You can alternate those, right? No more than 15 minutes of ice or 30 minutes of heat. Otherwise, you kind of lose, you end up with the opposite effect. The ice starts to cause pain. Or it's just not working as well. Physical therapy, massage, gentle stretching initially. You're going to learn to strengthen those muscles. Remember, the core are the area around the injury. Nursing care plans, acute pain, deficient knowledge, risk for impaired adjustment. How well are they coping with not being able to run marathons anymore? Back pain with a herniated disc. Rupture of the cartilage surrounding the disc with protrusion of the nucleus pulposus. You might have radicular pain or pain that's, you know, reading down to another area from the back to the leg along that nerve root. Matt said we got some pictures coming up. Common sites are L4, L5, or C5 and C6 up in your neck. The outer annulus fibrosis in the inner part of the nucleus pulposus. You can see this right here in these stages of herniation. Holy cow. So you can see this is degeneration. This can happen over time. It can be acute, like in a crush injury. Think about this thing like a donut, a jelly donut. Here's your jelly. Here's the outer part of the donut. So this can happen over time. You got a little fissure in there, a little crack. But it's starting to bulge. You're going to start feeling that pressure on the nerve. Or it can totally herniate. Or sequestration when you lose that. When it bulges like this, just think, whenever it's going outside of its normal spot, you might end up having pressure on other areas. So that's when you might start feeling the pain. L4, L5, you think of that sciatic area, and that's what can radiate down and around and down your leg. But if this happens over time, your symptoms can develop gradually. If this happens abruptly, where I bent over and boom, I had that instantaneous pressure from my arthritic areas around, just kind of pushed that jelly donut, squished that puppy out, and or bulged it, and got that instant, and it's acute and it's very painful. If this happens and you have that instant compression, because these are your cushions in between your vertebrae. Those are your cushions. You want to keep those donuts intact as much as you can. When you bulge it like this over about a period of 3 months, 12 weeks or so, this will usually kind of dehydrate. And then you'll still have this part here, so you have some cushion left. But that'll dehydrate. But you still have something separating your vertebrae. This is where you run into trouble. Because once that herniates, you usually end up dragging a leg behind you. And it's like, oh, I've got such acute pain that I can't walk, or I've got nerve involvement to where I've got mobility issues now. And they've got to go in and they've got to fix that right away, because that can become permanent. So you have to either relieve the symptoms or they can become permanent. All right? You don't want to keep pressure on the nerve long term. So this is the nucleus pulposus, is your jelly. You don't want to lose that. So we'll talk a little more about it. Where do I want to go with that? Is it 56? Oh, okay. Well, you can look at this in your own time, but you can see wherever that nerve is, the different areas of your body it can impact. Okay? This is Empie. I threw it up there just for your information. Here's your dermatomes. So if you pinch a nerve here, look where it affects. Pinch a nerve here, what does it affect? Don't forget that bowel and bladder. Gradual herniation. Oh, as far as the herniation, sorry, didn't want to miss that. I mentioned that you can do a gradual herniation, right? That's where I'm at right now. Osteoarthritis is a good nasty reason for that. You develop a slow onset of pain and neurodeficits. And I showed you that one picture of that annulus where it was, you see that crack in there? You can have something like this happen over time. And you'll see people like me that will sometimes, you'll just think about a cat that wants to curve their back. I'm trying to do that to open that up, to try and get that pressure off that nerve. All right. So manifestations, lumbar disc. You have recurrent episodes of pain in the lower back with radiation to the buttocks and the leg. You have pressure on the sciatic nerve, and you have to watch for bladder dysfunction. Motor deficits, weakness of various muscles. You can end up with foot drop because you end up with that peroneal nerve being involved on the anterior part of your tibia. You can have sensory deficits or paresthesias with numbness and tingling. Think about a cervical disc. Think about where is the area being involved and what does it affect. With your cervical, you can have pain in your shoulder, arm, neck, bless you. Neck pain in the shoulder. I said neck pain in the shoulder, arm, neck, yeah. Paresthesias or abnormal sensations or muscle spasms. So think about what area is being affected and how much can it affect. You know, how bad is the compression and how much jelly are you losing or being protruded. Usually they're going to do an MRI, CAT scan. They might just do a plain x-ray if you've never had one done before, because they want to see the abnormalities in the bone structure. Think about if you've had a prior trauma, if you've had plates and screws, reconsider what are they made of, can they have an MRI done? Non-ferrous metal is okay, or iron. Remove the body, make sure if somebody's going in for an MRI, you take all that jewelry off, external watches, rings, glasses, earrings. Think about, do they have stents or clips involved? If they had an old brain aneurysm that was clipped years ago, what are those clips made out of? Fillings, usually in your teeth, don't have iron in them, so they're usually okay. Are the people claustrophobic? Can they tolerate it? Do you have to give them some sedation? There's bigger MRIs built for bigger people nowadays. They might also do an EMG, which to check the electrical activity of the muscles at rest with voluntary contractions. They want to know what muscle groups are affected. They also might do a myelogram. That's where they inject dye into the subarachnoid space. Medications, analgesics, painkillers, right? NSAIDs, muscle relaxants are most commonly prescribed are going to be your Scalexin, Robaxin, Flexeril, maybe some Valium, Mother's Little Helpers from the 50s for anti-anxiety. Make sure you do the teaching that's involved with these drugs. Treatment, conservative for 2 to 6 weeks. They'll do this approach first, decrease your activity, take your drugs, physical therapy, and mild exercises. Alternative therapies include acupuncture. Those are triggers to release of endorphins. Acupressure. That's with their pressure with the fingers, not needles, right? Or a massage to improve blood flow. Do we have surgery up there? Yes. Okay. A laminectomy, removal of part of vertebral lamina to relieve the pressure on the nerve and able to get at the herniated disc. They're actually able to do some of this stuff outpatient. Discectomy, or removal of the disc. And it's usually removal of the herniated nucleus pulposus. You only remove the ruptured portion if you can, because remember, that's all you have. That's all the cushion you have. They try not to remove total, otherwise your vertebrae are going to come right on top of each other. Decompressive laminectomy is a laminectomy with removal of the arthritic bone spurs and additional bones. Sometimes requires a spinal fusion, and they can do that with your own autograft, which means self. And they'll usually take it off the hip, off the crest of your iliac crest. But they'll use, my Aunt Mary said they built me a ladder. So they took some bone out of her hip and rebuilt her spine. And they'll usually fuse those spots. It's permanent. You're not as flexible in that area. Okay, does that make sense? Were you going to say something, Matt? What?
Well, there's also something called a nucleoplasty.
Nucleoplasty?
Where they actually take a probe and they go into the disc and they heat it up. And that heating up reduces the pressure inside the disc. And so the bulge can go back in.
And it's called again?
Nucleoplasty.
Nucleoplasty. So they're going to stick like, is it like a heat?
It's like an electrode that heats up. Yep.
I'm trying to think of, is it fiber optic or?
No, it's just a little.
So okay, so you got a probe that goes right into the nucleus, heats it up, and it's interesting. Let's boil it for a little bit and decrease it down a little bit, boil it. So they're trying to decrease the bulge in the disc. Very interesting. Cool. Cool stuff. Should have had that done. So if they're going to do a decompressive lammy, they're usually in the hospital for 2 to 3 days. Some of you have cared for patients with what's called spondylolisthesis. They have a decompressive lammy with a lumbar fusion. Those patients are going to wear a back brace It's firm in the back, sometimes softer in the front. They're going to wear it every time that they're up, and for about 3 months. A lot of times these patients will go to rehab, and anytime you have, and it depends, make sure you watch your orders. It might be anytime that they're more than 45 degrees, they might have to have it on. When my aunt had her back surgery, they had her up out of bed the next day at age 89 or 90. They had this brace on, and she was up walking around. But make sure that you check your orders. Can I have them up 30 degrees without the brace? If I'm up at 45 and they're eating, do I have to have the brace on? Or is it only when I've got them sitting at the side of the bed or out of bed? So make sure you look at your cardexes and check to make sure you're giving the proper treatment for that patient. Safer to go through the, oh, okay, so if you're doing a cervical fusion, before I do that, when those people are like that, 89 years old, and they've got something that they have to really watch, that type of stabilization, they usually will go to rehab first. Cervical fusions are usually done anteriorly because there's less chance of causing trauma versus going posterior. It's more convenient. The disc can be reached without disturbing the spinal cord, the nerves, and the strong muscles of the back. So you want to avoid cutting into those muscles if you can. The cervical vertebrae are smaller, and they always fuse it if they go in. Bone for fusion cervical can come from a cadaver, which is called allograft. Your own bone, I mentioned, is autograft from the iliac crest. It'll grow cells. Say again?
That's on the next slide.
Okay, let me go to that. There you go. Losing my voice, man. Cadaver allograft. Okay, cells, so autograft, you got grow cells and proteins, so it'll obviously heal a bit faster. You might hear for an anterior cervical fusion, also called an ACF. The bone does not heal as well if the patient smokes. Sometimes the surgeon might use a metal plate to support the bone because it doesn't want to heal as well. You can see incision on either side sometimes. Just depends on physician preference. They try to spare the nerves of the voice or your pharynx. Usually home within 24 hours. Oh man, I'm almost done. We're obviously not getting to neuro. No NSAIDs because it can cause bleeding, interferes with bone healing, and no smoking because it delays. Whew, I need, oh, we got to finish this, guys, because we're way behind. I'm looking for anything. Ha! Oh, this is what I, see, I didn't have my coffee.
You want to talk to
I might take you up on that in a minute. So, are we on nursing diagnosis yet?
next slide?
You guys can read. Acute pain, incisional pain. Think if they got extra implants or plates. Chronic pain they might have to be dealing with, because especially when you're looking at back surgery, there's no guarantee it's going to work. Constipation. Remember, narcotics. Low back pain due to meds. Inactivity. Hurts to sit on a toilet seat even. Limited mobility. Especially if they do a fusion, they'll have to wear a brace, but eventually it will get better mobility. My aunt was able to do just fine. Self-care deficit, especially in the elderly, they usually have to go to rehab. Difficulty just bending over to tie shoes for about 3 months. There's usually 3 months, 3 to 6 months for healing. So, immediate post-op lumbar lambie, there's concerns. You pay attention if they've got numbness or tingling, because you might have a problem with swelling in that area, and it could be a medical emergency, because you got to do something to alleviate that, or it's going to become permanent. So you watch for numbness and tingling in the feet and the legs. Cervical, you're looking at the hands. You know, just think of wherever it is and below that point. And look up your terms. Spondylolisthesis is the bones in the spine slip on each other, most common L4, L5. Spondylolysis is a small fracture in the back spine. You'll see that commonly in L5 to S1. That's common in athletes with hyperextension movements. I see that. Fusion arthrodesis. We talked about allograft, autograft. And that's all I got to say. Holy cow.